Today's episode of Knoxville Medicine Doc Talk is sponsored by London and Amburn, Attorneys at Law, Healthcare People, Healthcare Law. London and Amburn, Attorneys at Law, are proud to support the Knoxville Academy of Medicine and its mission to continue to improve community wellness in East Tennessee.
Hi, welcome to Doc Talks. If you remember, Doc Talks is the podcast put out by the Knoxville Academy of Medicine, where we talk about health issues affecting all East Tennesseans in plain language. I'm Elise Denaney, former president of the Knoxville Academy of Medicine, and today I have joining us Dr. Bedford Waters, who is the professor and chairman of the Department of Urology at the UT Medical Center, Knoxville. We're so glad he's going to join us today to talk about prostate cancer. A lot to learn about that. Thank you for joining us, Dr. Waters.
Glad to be here.
Okay, so let's just start from square one. What's a prostate?
So the prostate gland is located, walnut-sized gland, between the bladder and the urethra. It is walnut size. After the age of 40, it starts to enlarge, and men will get some symptoms related to urinary obstruction, difficulty starting the stream, getting up at night. You may have a little bit of blood in the urine, and that's benign enlargement of the prostate gland. As you get older, those symptoms may increase. Now, prostate cancer, on the other hand, develops in the gland in a large number of men. As we get older, by the age of 80, 85, we'll all have some prostate cancer in our gland, but that prostate cancer most likely will not kill you. You will die with it and not die from it.
Interesting. Very interesting to know. I know my age, I'm getting up there in age, and so a lot of my friends have to get up, go to urinate, pee at least 2 or 3 times during one night of sleep. Mm-hmm. They have to get up and pee. Should they be concerned about that?
Well, certainly if they're getting up 2 or 3 times at night and they can't go back to sleep, then they should talk to their primary care physician, or if they have a urologist, talk to their urologist.
Okay. And you mentioned seeing blood in their urine when they urinate, when they pee. If you see blood in the toilet bowl, that's not a good thing.
That's not a good sign.
Okay. And it doesn't hurt. What if it just hurts when they pee?
So if it hurts when you pee, you may have a urinary tract infection, and certainly that deserves attention. Anytime you see blood of any type, you need to contact your physician.
Okay.
Because it could be a urinary tract infection, it could be a prostate infection, or it could be signs that you may have advanced prostate cancer.
Can it creep up on you silently?
Yes. In the past, prostate cancer used to be a silent killer. When I was in training, 60% of patients who presented with prostate cancer had prostate cancer that was already metastatic, not localized, and not curable.
So, silent. Okay, so you don't know you have prostate, and you said it already was. What is metastatic?
It had spread outside of the prostate.
Oh, okay, so inside your stomach or to your bones?
Usually it goes to the lymph nodes first.
The lymph nodes, okay. So we if it's silent, how do we know if we have it?
Well, you know, that brings up a point about screening for prostate cancer, which has caused a lot of controversy. Back in the late 80s, there was a blood test developed called PSA, and it was thought to be a screening test for prostate cancer. Prostate cancer, after PSA started to be used, there was a increase in the diagnosis of prostate cancer for a period of time, and then the incidence of prostate cancer went down. Well, everyone thought that PSA screening was a good thing because picked up all this newly diagnosed prostate cancer. So then there were groups that advocated screening, groups that did not advocate screening, and it became a big controversy. People were saying that we were diagnosing and treating too many cases of prostate cancer that was indolent and would never harm or kill the patient. That's where the controversy came. And then the U.S. Preventive Task Force Services, which is a U.S. agency composed of different physicians and lay people, made a recommendation that prostate cancer screening should not be done, and it gave it a D recommendation. Now, there were no urologists on the Preventive Task Force. There were no medical oncologists on the Preventive Task Force. But they felt that we had diagnosed and treated too many patients, some with harm, from the treatment of prostate cancer. And they felt, therefore, no one should be screened.
Well, I think there is value in screening. When do we screen ourselves for prostate cancer?
Well, there have been different recommendations by different organizations. Now, the American Cancer Society recommends that everyone should be screened starting at age 50 for prostate cancer. If you have a family history, or if you're African American, which are two big risk factors, meaning that will increase your risk of getting prostate cancer 2 to 3 times, then you should start at age 45. The American Urological Association, after the U.S. Preventive Task Force came out with their D recommendation, they changed their recommendation so that in 2015 or so, they made new recommendations that the ideal age to start screening, or patients who would benefit the most, was at age 55 through 69. Now, the AUA did not make any recommendations for patients who were African American or if you had a family history. Now, the other controversy came that men over the age of 70 should not be screened. Now, there are some very healthy 70-year-old men that have a 10-year life expectancy or greater. And that's something that you need to have a discussion with the patient to see if they will want to be screened. Now, in 2018, the U.S. Preventive Task Force has retracted or come out with another recommendation giving prostate screening a grade C, meaning that you should talk to your physician, have a discussion about the risk and benefits of screening, and if you feel it's valuable, then have the test done.
Absolutely. Talk to your urologist because they know best all the factors that are involved in putting you at risk for developing prostate cancer. And the screening test is really just a blood test.
It's a blood test, and you should have a rectal exam also.
Okay.
So you should have a combination of a rectal exam and the blood test. We discourage people from going to mass screening fairs at malls where the blood test is just drawn.
Okay. Yes, you should have a rectal exam. That's very important because sometimes the blood test won't pick it up and the rectal well, is that why?
Real.
Okay.
Perfect example, when I was in Chicago, at Loyola University, my nurse in the cancer center, her husband was 46 at the time. Family history of prostate cancer. He had a PSA drawn by his primary care physician. It came back 0.6, which is normal. I said, well, did he have a rectal exam? And she said, no. And I said, well, bring him in and let me examine him. I did, and he had a hard nodule on his prostate, which I biopsied, and he came back Gleason 3 + 3 = 6, prostate cancer. I did a radical prostatectomy on him, and he today is alive, and his PSA is undetectable. So there's a perfect example of someone who only had a PSA, and had he not had the rectal exam, that would have been missed.
So it's important to have both.
Both.
Absolutely. So if you're PSA and you discover that on rectal exam it's large, what's the next step?
So if you have an enlarged prostate, that can cause your PSA to be elevated.
Okay.
So there are several things that will cause your PSA to be elevated. One is benign prostatic enlargement, or BPH. The other is if you've had an infection, a urinary tract infection. Usually patients will have symptoms of that. If you've had recent instrumentation, Foley catheter put in, if you've had a cystoscopy, even sometimes if you have your PSA drawn the next day after having sexual intercourse, that can raise your PSA by a small amount.
Okay. If it turns out that you do have, how do you diagnose prostate cancer?
So if the PSA is elevated, and there's no absolute value now. When PSA first came out, 4 was the number that was considered, if it was over 4, it was elevated. Then it came down to 2.5, and in some studies, 3. What you want to do is get a baseline PSA. Then you look at the patient, his life expectancy, if he has a family history of prostate cancer, or if he's African American. And then, based upon that, you look at the trend in PSA. And if the PSA is going up more than 0.5 nanograms per year, or if you see a big increase from one year to the next, that should cause concern.
Okay. Is there a reliable, all these genetic tests that are out on the market now, do you recommend any of those?
Certainly there are some tests that we are using in addition to PSA to help us have more data points to decide if someone needs biopsy.
Okay.
So there's a 4K score, there is another score, it's a urine test, and so we're using those in addition to PSA.
And I love that you said that even if you have prostate cancer, it doesn't mean you're going to die.
No, it does not mean that it's a death sentence. And certainly, if you are diagnosed with prostate cancer, which requires an ultrasound and a biopsy. Now, 10 years ago, there are horror stories about prostate biopsies. And men will tell you it was the worst thing in my life. And it probably was bad back then. We now use a block. So a prosthetic block is used just like the dentist does when he works on your teeth. The majority of patients will feel discomfort or pressure, but not pain.
Okay.
So in my practice, approximately 75% of the biopsies I do are done in the office with a block. There are certain patients that want no part of it. And so we do those under sedation.
I've had people, my dad would probably want to put me out.
Right. Now, I've had 2 prostate biopsies. I had one under sedation, and I had the second one in the office.
And
the second one in the office was no sweat.
that's good to know. So guys, you do not have to be nervous about this, and it's not a big deal. That's very good to know.
Right.
All right. Are there any other signs of problems going to the bathroom or having a bowel movement?
Not really. Certainly, when patients have symptoms and signs, meaning more difficulty going to the bathroom, and you realize that maybe this is not just benign prostatic hyperplasia. Usually when patients have symptoms, then the disease is usually the horse is out of the cart.
Okay. A biopsy does not cause impotence.
No. Now, there was some data presented that, depending on the number of samples taken, that some patients have complained of temporary erectile dysfunction after a biopsy. That's rare, and it usually returns within 2 to 4 weeks.
Okay, so that shouldn't be a deterrent to having a good health.
Right.
And pursuing good health.
And also, people have the idea that the biopsy is going to get cells out into the body.
Oh, right.
That's a misconception, and that's not true.
That's not true. Sometimes there is a lot of misinformation out there that somehow finds its way into people's minds.
I know. If you get on the internet, that's the worst thing you can do, because there is so much bad misinformation about prostate cancer.
Oh. Well, thank you. Is there any final word that you want to share with us that our listeners need to know about prostate cancer?
Certainly, prostate cancer is the most common cancer in men. Certainly, we need to be smart about our screening. You should have a 10-year life expectancy and have no major medical comorbidities. If someone has diabetes, if they have bad heart disease, bad lung disease, they will probably die of that disease and not prostate cancer. So those patients should not be screened.
That's amazing.
If you are diagnosed with prostate cancer and you're diagnosed early, you can be cured and live a long, healthy life. Yesterday was the 6th anniversary of my having my radical prostatectomy done.
Yay!
For early stage prostate cancer. My PSA is undetectable, and I've had no major side effects from the surgery.
So there you've had it. Not only he is the professor and chair of urology, but he is a survivor, which is, to me, even more credible. That's amazing. That's just brilliant. So thank you for joining us today and having this discussion, although it's very brief, on prostate cancer. Dr. Waters, if people want to get a hold of you and ask more questions or come and seek consultation, how would they do that?
So I'm at University Urology at the University of Tennessee Medical Center. Our office number is 865-305-9254. We do have a website, www.universityurology PC. And we have 7 partners in our group, and we all see and screen patients for prostate cancer. We have 2 surgeons that do robotic prostatectomies. I don't do robotic surgery, but 2 of my partners do, and they do an excellent job.
Now there's a topic to discuss in the future, robotic surgery.
Yes.
You're a great plant. Thank you for joining us today.
Thank you.
Thank you so much. And that's a wrap.
Today's episode of Knoxville Medicine Doc Talk is sponsored by London and Amburn, attorneys at law, healthcare people, healthcare law. London and Amburn, attorneys at law, are proud to support the Knoxville Academy of Medicine and its mission to continue to improve community wellness in East Tennessee.